Welcome, everyone. I am Rachel Hughes, Community Manager here at Alloy Women's Health. We are a digital health platform bringing science-backed, evidence-based menopause hormonal solutions direct to your door. I am pleased, as always, to welcome back to our platform Alloy Medical Advisor and Prescribing Physician, Dr. Corinne Menn. Dr. Menn is a board-certified OBGYN and Menopause Society certified practitioner. She is also an over 23-year survivor of breast cancer and premature menopause, a BRCA carrier, and uses her experience to help women navigate their own health challenges. She has dedicated her medical practice to menopause management, the unique healthcare needs of female cancer survivors, and those at high risk for breast cancer. Now practicing exclusively through telehealth, Dr. Menn provides women's health consultations and patient education. Finally, before we officially get started, I want to let people know that this webinar will be shared on our YouTube channel at the conclusion of this live, and that we're offering for new customers a perimenopause promotion at myalloy.com. You may enjoy 40% off your perimenopause consult with one of our menopause specialists. The promotion runs through midnight, September 22nd, which is now known as World Perimenopause Day. And the code to use is PERI, P-E-R-I. Existing members will receive a different code direct to your email. So Dr. Menn, welcome again. Our webinars are particularly focused on answering the questions of women here on the call. And before we get to those, I wanted to sort of allow you to set the stage on today's topic, perimenopause, by giving us a one-on-one, if you will, about this life season. And with that, you have shared with us that you were just recently at the annual Menopause Society meeting and you had some takeaways pertinent to this conversation that you wanted to share with all of us. So I'm going to hand it over to you and we'll get cracking on what you have to share.
Yeah, I just want to start out to say that perimenopause is probably the trickiest thing for women to navigate just because the symptoms are so varied and it's coupled with often bleeding issues and contraceptive concerns. And so it's challenging for women and it's extra challenging for doctors. We always talk about the fact that most physicians, OBGYNs, primary care doctors, and other specialists have never had proper professional medical education on menopause. They really haven't been educated well on perimenopause, which I think makes Alloy super special because all of our doctors are board certified and are, part of the Menopause Society. They're certified clinicians in menopause and have a ton of expertise. And what I have found in my practice is that it really takes expert knowledge, particularly to manage the perimenopause. And yes, we were just at the Menopause Society annual scientific meeting. A number of the Alloy doctors were there, and we all, took a lot of take-home pearls. There was a lot of sessions specifically on perimenopause, symptom management, management of bleeding, the physiology of perimenopause, as well as a lot of sessions on hormone therapy in general, also brain and mood. So we'll tie that all in on the webinar.
Great, fantastic.
But I thought we would get started first by just reviewing the physiology of perimenopause, because between social media and my patients at Alloy, we always get questions that I can tell patients don't really even know what's happening to their body. So I thought it would be fun we're going to run through some visuals so that we can just learn what is the physiology of the menstrual cycle and of perimenopause. And then we'll get into all the questions that women have. So let me just screen share. I always say a picture is worth 1,000 words. So it does. It really can help us. So can you see the screen, Rachel?
I can. Yep.
Perfect. Okay. So what I wanted to first, and jump in at any time and ask questions.
Sure.
Let's just spend a little bit of time here because it's really important for women to understand their bodies. Okay. So this is a menstrual cycle. So at the bottom, you see, this is supposed to represent your endometrial lining. Okay. And this is what builds up, as you can see. So day 0 through day 28. I really want to spend time understanding this picture. So at the beginning of your menstrual cycle, technically day 1 or day 0, that's the day that you get your bleeding, okay? So All right. And so you can see the linings breaking down this little graphic here and shedding. And then over the next, on an average cycle length, 28 days, that lining is building up, kind of prepping for a pregnancy, right? And if you're not pregnant, it all sheds and everything starts over again. So the bottom is the endometrial lining. And remember, this is a normal, premenopausal or your reproductive years cycle. And now let's go into the middle and look at what's happening with your hormones. Let's just look, let's focus on yellow, that's estrogen. And then the blue is progesterone. So in the first half of your menstrual cycle, your brain is sending a message to your ovaries to start producing estrogen. And as you can see, the estrogen level slowly starts to rise and it peaks right around right before day 14 when we think about ovulation, right? And then it kind of dips again, and then you get another little bump up in your estrogen. And that's the normal up and down of your estrogen. At the same time, you've got the blue line here, that's progesterone. And if you notice, progesterone doesn't get produced until the second half of the cycle. So the first half of your cycle, we call the follicular phase. And then the second half, after you ovulate, see these top things appear, the luteal phase. And, people often ask about FSH, that's follicle stimulating hormone. So that hormone's coming from your pituitary gland in your brain, and it's the messenger to your ovaries. That is the signal, say, hey, ovaries, start making estrogen. So as you can see, that FSH rises, and as it's risen, you start to have the yellow line estrogen go up. And when estrogen is sufficient, estrogen's got to get to a certain amount. And once it gets to a certain threshold, you get something called luteinizing hormone, LH. So FSH and LH, those are the two hormones. Those are the signals that come from your pituitary to your ovary. So you get, when you have enough estrogen on board, you get something called an LH surge, okay? That little LH surge tells your eggs to ovulate, tells the follicle to ovulate. So you get ovulation.
Okay.
All right, so now let's move up to this last thing here, the follicular development. So this is showing what is actually happening in your ovaries. So you have a little follicle. The follicle is getting recruited by the hormone FSH and estrogen, and it's telling that follicle to grow, get bigger, get more mature egg. And then right after the estrogen peaks and you have your LH surge, that's the signal for ovulation. And so the little follicle ruptures. Some women actually can even feel it.
Yeah.
The name is called Mittelschmerz, which is a funny name. But people will, and it alternates, right ovary, left ovary. And once you ovulate, you get something called the corpus luteum. And that's what this little white kind of funny little picture here is. And what happens is on your ovary, where that follicle has ruptured, the corpus luteum is responsible for making the progesterone. So this is super important. If you are not ovulating, you're not having progesterone being secreted in any significant amount, right? Okay, but in a normal menstrual cycle, this is what is supposed to happen. So as you can see, there's sort of a balance and a dance between estrogen rising and then progesterone. And so that's really important for you to understand a normal cycle, because as we enter the perimenopause transition, which can be up to 10 years prior to your final menstrual period, the last time you have a period, and then you enter your postmenopausal years, that's a long time. So there's a lot of changes that are happening then. And before we get into what it actually looks like into the hormone levels, I want everyone to just remember every cell in your body has estrogen receptors, progesterone receptors, and also testosterone receptors. We're not going to talk about testosterone so much today. We're focusing on estrogen and progesterone. And we're not going to read through all of this, but it's just important for women to understand that estrogen and progesterone, impacts every organ system in your body, from your brain to your heart, to your skin, your joints and muscles, your nervous system, your bladder, your vagina, right? And then just take a minute, and on the right-hand side here, let's just look about what is the influence of progesterone. So let's just look a couple here. It's secreted from the ovaries. It gets the body ready for pregnancy in terms of the uterus and the breasts. And so if you're not pregnant, progesterone levels goes down. When progesterone levels are lower, or you are not producing a lot of it because you're not ovulating, you can get heavy bleeding, sleep disturbances, anxiety, and migraines. So those are just some of the symptoms, right? Breast tenderness is super common because what happens is in perimenopause, you're still making estrogen, right? But you're not always making a lot of progesterone because you're not always ovulating. And the estrogen levels can really fluctuate from kind of, trending lower to fluctuating to higher levels. I want to show you a graphic of that to kind of put it into perspective. So like, look here in premenopause or just your normal, reproductive years, see this beautiful up and down. It's very predictable and even of the, dark blue line is estrogen. It's going up and down, right? You've got the progesterone. I'm sorry, the green line is estrogen with the two peaks that I showed you, and then the up and down of the progesterone. And then the dotted lines are those messenger hormones, FSH and LH. So in perimenopause, it is all over the top, okay? So if someone says, well, I did my blood test and they said my estrogen level was high, so I can't be near menopause. Well, you sure could, because you could have an irregular, erratic spike of it. Or they said, I had my level done and it was really low. Well, it was low on this day, but not on this day, right? So this is why blood levels are really inconsistent. They're just a snapshot in time. And then if you look at postmenopause, so this is after you've had your final menstrual period. So the green line, your estrogen levels are uniformly low and even, same with the progesterone. And what happens is your FSH, which is the dotted bluish green line, once you're menopausal, your FSH stays high, like over 30, often much higher, and your estrogen levels are quite low, right? So it's the perimenopause with all the craziness. I call it like a roller coaster. Here's another image, kind of a similar, image. And this was a study that was done actually almost 20 years ago. This was an image referencing a study by Nanette Santoro. She's a leader in the Menopause Society. She was the one who, and her colleagues, did a ton of work documenting what is actually happening to estrogen and progesterone in perimenopause. And they measured it on kind of an average over 180 days. And you could see how it was so unpredictable.
It looks as challenging as it feels.
Yes, but if we understand the physiology, it really helps us understand what's happening to our bodies and how we can manage it.
And can I pause you just for a second? And if I'm jumping the gun, just route me. But I'm thinking about the first illustration, the third illustration, and the testing that you mentioned. And I just wanted you to hover just a minute more about why this illustration really indicates that testing is unnecessary. Because I'm thinking about, you're mentioning someone saying my estrogen level was high on this day, but it can even be high in an hour on that day. Is that correct?
Absolutely. So, your ovaries are, continuously in, premenopause and perimenopause producing estrogen from low levels. And, to kind of put it in context, low levels, we measure in picograms per milliliter. Don't worry about that so much, but just about 30, right? When you're still, before menopause, and it can peak to higher than 400, 500. And the average, if we kind of looked in our premenopause times, if we averaged it over the month, it would be in the low 100s, 100, 120, if we averaged it over the month. But you could see even in your premenopause years, it can go as low as like about 30 and spike up to about 400 and back down, up and down and up and down. So when we're doing, when people are having hormone levels measured when they are premenopausal, say for fertility and stuff, they have a predictable period. So we know what time of their menstrual cycle they're getting that blood drawn. And we can predict, often, it would be recommended on like day 3 of their menstrual cycle when we're trying to figure that out. But once we go into the perimenopause time, we have no way to predict where you actually are in your menstrual cycle unless you're having extremely regular periods. And the reality is, women who are having extremely regular periods tend not to have a ton of perimenopausal symptoms, although they can, because you could still have regular periods and the hormone levels are trending a little bit lower than they were. But typically, symptoms go hand in hand with the irregularity, And as you mentioned, you could have a couple of months where your cycles are really clockwork. And then you can have a couple of months where they're all over the map. And the idea is that it's trending towards lower levels of estrogen, lower levels of progesterone. But before you get there, you could have so much erratic production.
And Dr. Menn, before you go on, I'm also thinking about, in looking at this graph, let's say the first third is a woman anywhere from, I don't know, 15 to 35.
Yes.
But I feel like as more of us sort of advance into our perimenopausal years, we're looking back on the start of this and concluding in many cases that we may have started earlier, years earlier than we remember our first symptom to be. And so, not to suggest that women should be assuming they're in perimenopause by the time they're 39, but I think one of the reasons your work is so impactful and what we're doing here is so helpful is that we're letting women know that things can be sort of, you know, in your landscape sooner than you think. So
Absolutely.
just tell us a little bit about, again, kind of how long this transition may last and how you know you've started.
Yeah, so the transition can last up to 10 years. So there can be very subtle changes. There could be dramatic changes. Why does it happen worse for some women than another? You know, we don't know the answer exactly to it. It's probably a mix of genetics, you know, hereditary factors. It could also be a mix of other stresses in your life, whether it's chronic medical stresses, whether it's psychological stresses, you know, other things going on that can impact our hormones and how we're feeling. And I'm going to touch and I'm going to show you some pictures of like fibroids and, you know, adenomyosis and endometriosis, because all of those things come to play. I flip back to this picture because I just wanted to kind of just bring you back to this lining picture, okay? And I want everyone to picture the lining. It's kind of like a lawn, right? It's been nice and trimmed down, and then it grows, and then it gets trimmed down again, right? So I want you to imagine if you didn't ovulate. So this little middle line here, okay? And imagine this line gets pushed out a little bit, meaning the estrogen keeps on being produced. You never get that LH surge. You never get, you know, that signal for the estrogen to dip a little bit and for the progesterone to take over. Understanding progesterone's job is to say to the endometrial lining, okay, you've grown enough. I need you to start to mature and get prepared for maybe a pregnancy, right? So it helps kind of with the unchecked growth that the estrogen is causing on the lining. So you can imagine if you just keep on having estrogen produced and you're not getting ovulation and you're not getting progesterone, that lining can get kind of thickened, right? Mm-hmm. And you may not get a period because you haven't had the progesterone and all those signals. So you can get kind of a thickened lining and your periods could start to be delayed where you're not getting a period for 6 weeks or 8 weeks. And then finally, when you bleed a lot.
Yeah.
You know, or what happens is the lining gets thickened, builds up, and you never actually get that signal for a period. So you have like the lining just becomes very unstable and you'll have like some spotting and then that'll last a couple of days. And then 2 weeks later, you'll finally have a bleed and it'll be really heavy. The opposite can also happen where the estrogen is just, you know, it's getting, you know, produced, but think about these little ovaries is they're getting a little tired, right? The closer you get to menopause. So this little hormone FSH is telling your ovaries, hey, make some estrogen. But the ovaries are like, I'm trying. And the estrogen is low. And so you don't get much of a period because you never produce like that much estrogen. And that's when women in perimenopause on some cycles, they haven't had a lot of estrogen production because the ovaries are kind of, you know, not doing their job that month. And that's when some months they'll have like hot flashes and night sweats. And that can happen for a bit of time. And guess what? Then the next couple of cycles, you can have regular, or it can go what we said prior, where you have a lot of estrogen. So that's why the symptoms can be so erratic. But I wanted women to kind of understand. Like,
it's fascinating and so helpful. I'm so glad you brought this today. And while you queue up to your next, I just want to let people know I see questions coming in. I am going to get to every one of them. I just want to give Dr. Menn a chance to walk us through this.
Yeah, so really, really quick here. So, people are like, well, what's happening with my hormones? It is a transition, right? So, we've broken it down into like late reproductive, meaning this is like the early parts of perimenopause. Your cycles are still regular. See, I'm looking at each of these boxes. They're slightly irregular. The FSH is still kind of normal, but the ovarian reserve is low, meaning those ovaries they're not doing a great job pumping out the estrogen. Then you
Right.
go into this early perimenopausal transition. The cycle lengths start to change. They may not be every 28 days, they may be every 40 days. The FSH really starts to vary, so it's not reliable. And then we get closer and closer to menopause. So your cycles are more than 60 days apart. FSH gets higher and higher. And then finally, we get into that early menopause where periods stop, the FSH is high, ovarian reserve is very low, meaning estrogen levels are very low. And so this is kind of our scientific, way we talk about it. And you mentioned about blood tests, and we're always telling patients who ask us, well, don't you need to check my hormones so you know where I am? And I just told you, it's so unreliable, right? So we really need to listen to women and what they're telling us. And here's just one, proposed way of like thinking about it. And, I use this loosely. So here's like 9 really common symptoms. So a new onset of heavier, longer flow. Your periods are shorter, or they can be longer. And a lot of common symptoms: sore, swollen, lumpy breasts. You're waking up in the middle of the night or having sleep problems, maybe more cramping, maybe some night sweats, especially right before you get your period. New headaches. We're going to talk about mood swings, bloating, and weight changes, even though you're still eating well,
Right.
doing your same exercise. So this is what we're looking at a constellation. Perimenopause is a clinical diagnosis, not a laboratory one.
This is fantastic. And thank you. I was going to say, while you're talking about symptoms, we have that common cluster that you just shared, but so many women, and I think this is where also it's helpful for women to have an idea of what may be coming. Not that everything is because of our hormones, but certainly so much is. So some of these other, maybe lesser known symptoms, if you might go.
Yeah. And so we all hear about hot flashes and night sweats. And I would say in the perimenopause, certainly women can have hot flashes and night sweats. We typically see those when the estrogen levels are getting persistently low, although they can happen for some women when we have just very erratic changes. What I often see first is insomnia, not being able to fall asleep or falling asleep, but not being able to stay asleep. We call it WASO, wakefulness after sleep onset. So these are interruptions in the middle of the night. And you might have a hard time going back to sleep. A new onset of panic attacks or feeling of anxiety. And it doesn't have to be that full-on panic attack that brings you to the emergency room. It could just be like suddenly just feeling like uncomfortable in your own skin, or just a little tightness, or like just, you just don't feel like yourself. It can come in a wave. You can have a shorter fuse. And this is where women often seek care from their internist or their OBGYN, and they immediately get put on an antidepressant when, I'm not saying that can't be helpful for some women, but we need to understand what is happening. And maybe it's also her hormones. And then also like the breast soreness or breasts being bigger or fuller, which we don't always associate with menopause, right? Because that's when your estrogen levels are lower. But remember, I showed you all those fluctuations can really lead to bloating and fullness and like worsening of PMS. And so, yeah, over 30 symptoms. And so kind of keeping a little log of what's been happening is really, really helpful, because you might see this kind of, commonality over a bunch of months. Like, wow, I keep on writing down that you're checking off all of these things, right? And I just wanted to touch on perimenopause and mood. This is a big thing that was discussed at the Menopause Society meeting. There's a number of sessions on the impact of our hormones on depression, anxiety, and mood. And we know that the perimenopause transition in particular is a really vulnerable time. I'm sure you have a lot of questions about that, or have heard from women, right, about their mood. And I like to point out that, there's a lot of things going on. Certainly midlife women have a lot of external stresses. But when we think that, I had mentioned to you that we've got estrogen and progesterone receptors everywhere in our body, especially our brain, and they impact neurotransmitters. Dr. Lisa Moscani talks about estrogen being like, a master regulator of our brain, right? And progesterone has a huge role as well, and it works on a lot of receptors. And we know that there's this constellation of having hot flashes in the center, that's what VMS means, vasomotor symptoms, having sleep disturbances, mood changes, and brain fog or cognitive changes. And these things all collide in perimenopause. And the vasomotor symptoms, hot flashes and night sweats, makes mood, sleep, and cognition worse, right?
Right.
And so they all feed on each other, right? And it's important for women to understand that. And I do just want to point out here, I want women to always think about, if you in your younger years had PMDD, that's premenstrual dysphoric disorder, or you had PMS, or you had postpartum depression, or you just had a history of major depressive disorder or anxiety, we know that you have a particular vulnerability at the perimenopause. And so what I wish doctors and women knew is that if you had those things in your younger years, you should be on high alert that when your periods start to change and you enter the perimenopause, you're at a much higher risk to have mood disorders and anxiety. And the reason why this is important is because women in the perimenopause transition are the most vulnerable to these mental health changes. The suicide rate is highest in the perimenopause transition. Prescriptions for antidepressants are highest. And at the same time, many women are going through other life transitions, right? Like, marriage changes, relationship, careers, empty nesting, all of these things. And so we really have to be respectful and empathetic that they're navigating those with all these hormonal changes that are impacting the brain, right? So I just wanted to touch on that.
Thank you for that so much, Dr. Menn. I do want to get to everyone's questions and I want to let you continue. I'm just thinking for a moment, though, if you would indulge me,
Yes.
about, and I know we're going to get really much deeper into it, but to your point about mental health issues, but also sort of longevity impact things like bone fragility, vasomotor symptoms, and its impact on sleep, what that does to you over time, and the offerings that women might get, antidepressants. But then there's also hormones as sort of a first line of treatment.
Mm-hmm.
And before we get too deep, and I know you're gonna get into it, but what role can menopause MHT play? And when does a woman, again, I'm thinking about somebody who's, in her late 30s, when does a woman consider MHT versus anything else that might be helpful and impactful both to her symptoms today and shoring up her future health?
Yeah, so this is why it's an excellent question. And there's a lot of points that you said there. I think the most important thing, and the reason why let me just flip back to looking at this, is the reason why I want women to understand this is so that they can understand the options, the solutions for treating it. So for instance, if in the perimenopause, because of the irregular hormones, you are having a ton of bleeding and you're having lots of irregularity, it's impacting your quality of life. You also have all the other symptoms we talked about: mood, hot flashes, vasomotor symptoms. But if you're bleeding a lot and it is, not controlled and really erratic and irregular, that's where we often do talk about using hormones, but in the form of hormonal contraceptive pills, like an oral contraceptive pill. And you and I talk about this a lot, that a lot of women have a lot of resistance to that because they feel like their doctors have not listened to them in the past, and they just want to throw a birth control at them. And I understand that women are frustrated by that. And for some women, certainly the birth control pill does not work. And we can explain that next. But when it does work, it can be a girl's best friend for at least a few years, or a number of years. Actually, it can be your best friend for up to 10 years, right? Or longer if you need contraception, Because I want to remind everybody in this perimenopause time, this is why I went back to the slide, you're still ovulating. We just don't always know exactly when. So the oldest woman I ever delivered she was 52 and she had twins and she hadn't had a period for a few months and she thought she was in menopause.
This gives me.
Yeah, and I put ultrasound on her belly and I says, oh, well, it's not menopause, but you're having twins. So, if you need contraception, if the bleeding is really irregular and bothersome, those are two reasons why we would lean into one of the contraceptive options, right? And why does that work? Well, because the signals, right, this FSH and LH, these dotted lines, these signals, when we give the birth control pill, it tells those signals, it stops those signals. So basically, you're not ovulating anymore. You're not having this up and down or this craziness. You have a more even amount of estrogen being given to you in the form of the birth control pill. So it's suppressing this erratic, production. And that's why the birth control pill can be really helpful. Because for many women in perimenopause, the symptoms are not from a loss of estrogen. That's why I wanted to show you this. It's from the erratic production. Okay. So it can be super helpful, and it's particularly helpful. Again, bleeding issues, you need contraceptives. If you have a lot of PMS or PMDD, that comes a lot from the up and down dropping. Where does menopausal hormone therapy fit in? Well, if you don't need contraception, if your bleeding is not the primary problem for you, right, and the erratic nature, many, many women, especially as we get into later perimenopause, they will report to the doctor, like, I'm only getting my period every couple months. It's pretty light. And I'm just having, and they tell me all of the classic symptoms of estrogen loss, joint pain, insomnia, hot flashes, night sweats. In those cases, we can give back, some estrogen as well as progesterone. Now, the biggest question is, how do we give it in perimenopause? Do we cycle the progesterone, or do you take the progesterone every single night, right? This is a super common question.
Yeah.
And so what we guide patients on is, if their periods are pretty predictable, and they may be every 28 or 30 days, or, roughly in that, range, and you really can kind of anticipate when they're coming, that's when we'll cycle the progesterone for the latter half. So days 14 to 28 roughly. So basically 2 weeks of progesterone. And then we just give back a daily dose of estrogen. And because of this, remember these lines, these up and downs of the estrogen, typically in perimenopause, we start with a lower dose of estrogen. Why? Well, when I give a little low dose of, and I brought a little of even Miss spray. So that's one of my favorites, because we could do 1 spray, 2 sprays, or 3 sprays. Okay. So the reality is, if you're this lady in perimenopause, let's just look at this, and I'm giving you Evimis, is it really helping you on the days that your estrogen level is high? No. But what is it helping with? It's helping so that you never have these troughs where it's really low. It's basically giving you a little buffer zone of an even amount. Now, some of those days of the month, you probably don't even need that spray, but it doesn't matter, because we're just giving an even dose, and it's extremely low. The amount of estrogen in menopausal hormone therapy is far lower than the spikes you're getting here. We're not giving you high levels of estrogen. We start with a low even dose, either a spray, a daily gel, a patch, or an oral estrogen. But typically we start lower, and there's an art to it. And sometimes a little bit of trial and error, because things are changing. If your periods are all over the map and you're like, I don't know when they're coming, but they're not very heavy, they're pretty light and manageable, we can give you back a nightly dose of progesterone. And getting back to this first slide where I showed you, that second half of the cycle, when you have progesterone being produced, if you're not ovulating very often and your estrogen levels are lower and you're not having that progesterone, giving you just a daily dose of progesterone can really be very, very helpful for symptoms, especially sleep, anxiety. And if their bleeding isn't extremely heavy and problematic, giving back some nightly progesterone can actually help keep this lining a little bit more organized and thinner. But I want to caution women to not think that menopausal hormone therapy is going to cure or fix you having really heavy, irregular periods. right? And so if you can't do a birth control pill, you don't like a birth control pill, although you could talk to your doctor about, there's lots of different types. There's birth control pills that have estrogen and progestin. There's ones that only have progestin. Sometimes in perimenopause, many women have a Mirena IUD or another brand of hormonal IUDs that only have progestin. They get inserted into the uterus and they protect the uterus lining so it doesn't get thickened up like in this picture. And so that can control your bleeding, give you excellent birth control. And then if you're having other symptoms, we can add back in a little estrogen or even some progesterone kind of to help you. So I've kind of mentioned we've got birth control pills, all different types, with estrogen, with progestin only. There's continuous ones. There's ones where you have a shortened placebo of just a couple of days. IUDs with or without menopausal hormone therapy, or just using menopausal hormone therapy. And then within menopausal hormone therapy, we can do progesterone alone. We can do estrogen with progesterone. So we have a lot of tools, and that's
a lot of tools,
and not just the hormonal tools. Here, I'm
right.
going to stop to share for a minute. A lot of hormonal tools, but we talk about the importance of the whole toolkit of lifestyle.
Yes. Yes. That's amazing, Dr. Menn. And I do want you to get back. I want you to get through your
I'm going to answer questions.
I do want to get to people's questions. And I'm also, as I'm listening to you, I'm thinking for anyone who is perhaps not an Alloy customer who's going to come across this conversation, I so encourage you to connect with a physician like those that we have at Alloy, who is well versed in this particular science. I'm listening to you run through really how nuanced this conversation should be between a practitioner and a woman going through it or thinking about the future of this, and having that kind of care and understanding about all aspects of her health along the fluctuating lane, as it were, is critical. Okay, let me get to questions. Hi, I'm on birth control for past 20 plus years, and was told by my gynecologist this should mask perimenopause symptoms. However, I'm finding I'm experiencing many of the symptoms: mood, anxiety, heart palpitations. It's very confusing, as what I've read, it really seems perimenopause. Can all this still happen even when being on birth control?
Yeah, listen, a birth control pill, your GYN is correct, for it can mask a lot of it, right? But at some point in time, as you get closer and closer to your ovaries no longer producing estrogen. Remember, birth control pills do not suppress every single ounce of estrogen from your ovaries. What they're suppressing is ovulation and suppressing the lining kind of from building up and you having, heavier periods and such. What I find is that for many women, the birth control pill may work for a long time and they feel great on it. But as they get closer to menopause, they notice that, they're having more and more symptoms. The reason why is there's probably a couple of reasons what's happening. The birth control pill contains estradiol. It is not estradiol. It is different than estradiol. It works on the estrogen receptors, but not in the exact same way estradiol works, right? The birth control pills also have a synthetic progestin, which is great. It's fine. It helps the birth control pill work really well. But for some women, that combination at some point in time just doesn't meet their symptoms. And so the challenging part is when women need contraception, but they're having these breakthrough symptoms. And so, sometimes we have to make choices and say, okay, if you're having lots of symptoms and you want to try MHT, it's fine. You either need to use a backup method, certainly use condoms or, another method of contraception. If you really need contraception, then that's when we can sometimes consider an IUD. But this is a common scenario, and it's okay to take a break and give a trial of MHT, because you know what? It's a trial. And if you go on MHT and, your periods come back and they're really irregular and it's not working for you, well, we can pivot, and this is why Alloy works really great, because, we often do need to pivot, modify the plan a bit, and you don't have to wait like 3 months for a follow-up appointment only to be in the doctor's office for 10 minutes. My patients message me and be like, hey, this is working, or hey, I'm having these breakthrough symptoms, and we can make adjustments really quickly. Oh, I just realized that's my dog that's popping
Yeah,
up.
I see. I figured that out when I heard it bark.
She's just laying there. So this is super common, and we can't check to see if you're menopausal yet if you're on a birth control pill,
Right.
because we can't measure your FSH and estradiol appropriately. So the only way to know is to stop it
Yeah.
if you get symptoms and if you get your period.
Thank you for that. And for, I think the reminder essentially that we are bodies in motion and change, and pivoting is often necessary, and hang in there and be patient. You will get to the solution. Okay, so grateful for this webinar. Thank you to both of you. Thank you. I'm 54, still very regular, but I've been using Alloy since June. I've been taking oral estradiol 2 milligrams, progesterone 100 milligrams, just began vaginal estrogen, yay, and M4 and tretinoin, great, are on the way. My question, oral estradiol is working very well for me. Is this okay to take long-term? I'd rather not look at transdermal due to finances and ease. Any data on this yet? Thanks so much.
Yes, it's a great question. Listen, oral estradiol is extremely safe. It's cost effective. It's easy to take. It's easy to remember. And I think that while there's a ton of chatter, you hear everyone talking about transdermal. Listen, we get this fear of oral estrogen because, again, of mismessaging of the WHI study. So let's just take a quick reminder that in the Women's Health Initiative, they were using conjugated equine estrogen and a synthetic progestin in their oral combination. And it was in women who were older, right? Most of the women were, over age 60, many much older. And so these women had other health risks, and they were being given an oral synthetic progestin with conjugated equine estrogen. So I always say that's like the worst case scenario. It's not really the worst case scenario, but that's a very different, formulation than using bioidentical oral estradiol and bioidentical progesterone. But even using those older formulations and looking at the data from women her age, the women that you're the patient who's posing this question, they found that in women who were her age, younger women, that there was really no statistically significant risk of blood clots or stroke or cardiovascular. But we saw that with the older synthetic formulations in the much older women. But even in those cases, it was still extremely low. And all of those, risks that we worry about were less than 10 per 10,000 women, additional cases. So still quite safe. So then when we talk about the younger woman and then we talk about using bioidentical estradiol and progesterone, we are really talking about an extremely safe and effective medication. And so it's a great question. And if women are doing well on oral estradiol as they get older, they don't necessarily need to change. They can at some point, but they don't have to. She sounds like she's doing great. She could probably stay on that formulation for a long time.
Thank you. Thank you for that. I'm in perimenopause. I'm an Alloy customer. I've been on Evamist and 100 milligrams progesterone for a month, which has helped my vasomotor symptoms. My cycle has been irregular starting 3 months ago with almost daily spotting, skipped a period, and now I'm experiencing menstrual flooding. Should the progesterone dose be increased to minimize the bleeding? I take the hormones daily currently.
Yeah, so this is an excellent question. And this is why you really need real clinical expertise, because all bleeding in perimenopause is not necessarily just hormonal, or, there's other things besides just hormonal shifts that can be causing it. So this is a good example of where there could be a lot of ways that we can manage bleeding. So certainly her question is, sometimes you need more progesterone. Absolutely. So that's something she could talk to her doctor about. Sometimes we actually need less estrogen. Sometimes we need to say, hey, your hormones are still really irregular, and no matter what dose of MHT we give you, it is never going to override what your ovaries are producing. So sometimes we consider using a oral contraceptive pill to kind of tamp down the crazy irregularity. The other thing is, and this is where it really becomes individualized, I couldn't answer that over a webinar, but that, there are other things that can happen, like fibroids and polyps, adenomyosis, other things, endometrial hyperplasia, things that we need to sometimes rule out And so you always want to report persistent or heavier bleeding, to your doctor. Sometimes we manage it with adjusting the medications, but sometimes we say, hey, here are red flags of where you need to have a little bit more further evaluation. And just along this line, I just wanted to get in, Rachel, that when women have really heavy bleeding, and not particularly to this patient's question, but many women come to us at Alloy with very, very heavy bleeding. And I always want them to make sure, one, that they're not anemic, that they don't have iron deficiency anemia. Because if you have iron deficiency anemia from heavy menstrual cycles, that can make your fatigue and even your insomnia and your night sweats worse. So we have to get that under control. And we also want to make sure your thyroid is in order. So luckily, many women have come to us and they're like, my doctor's done all the blood tests. We already have this. This is normal. This is normal. But I always want to remind women to also, we can't blame everything on perimenopause.
Right. Thank you for that, Dr. Menn. I want to defer to you on a couple of questions I'm seeing about breast cancer. You are going to be asked these kinds of questions all the time, but I know, speaking of nuance, this is even more so and warrants private time with you. That said, if you could just sort of give us broad strokes around what we know to be true as far as menopause hormonal therapy and breast cancer risk, correlations, none, myths, truths, and so on.
Yeah, well, and before we even talk about breast cancer and MHT, it's really important for women to know you're perimenopausal. This is around the time where if you haven't turned 40 yet, you're going to be turning 40 soon, and this is when your mammogram screening, your breast cancer screening is starting. And as of Tuesday, FDA is requiring that all women are notified of their breast density so that you get the best screening. All right. So let's just touch on one thing I want all women to know, regardless of whether you're using hormones or not. We want to individualize your breast screening. And this is a really good time to know what is your risk, your baseline risk of breast cancer, because many women don't realize it. So you want to know your family history, your breast density, other factors, and kind of know what your individualized risk. And I mention this because there are many women who might qualify for genetic testing. They may qualify for enhanced surveillance with breast MRIs and breast ultrasounds. So we want to tailor your breast screening. That being said, this is like the simple version of how I like to explain it. Your breast cancer risk is your breast cancer risk, right? And you should know what it is, and it should be individualized to you. But say the average woman's risk is here, right? If we give you menopausal hormone therapy, it doesn't change your risk. It doesn't make it higher. It doesn't make it lower. It doesn't change it. So the Menopause Society position statement is quite clear on this, that the preponderance of evidence and all of the data thus far suggests that menopausal hormone therapy does not further increase your risk. If you have a family history, if you are a carrier of some genetic mutation like BRCA1 or 2, if you have dense breasts, fibrocystic breasts, all of these things may increase your risk at baseline, and we're not further increasing it, okay? So that's it. And we know that estrogen alone in the WHI, as well as other studies, has been shown to lower the risk of breast cancer. And then the risk that is attributed to estrogen with the synthetic progestin in the WHI study, that risk was exceedingly small and similar to other modifiable risks like cutting out alcohol and exercising and being overweight, right? And the risk was so small that some argued that it wasn't even statistically significant. But if we take it at face value, it's a very small risk, and we believe associated with the synthetic progestin. And that's why these days we lean on, if we need to use progestin or progestogen, we use progesterone, bioidentical progesterone. And in observational studies, that has not been shown. Progesterone has not been shown to be associated with an increased breast cancer risk. And then birth control pills, I want to remind women, the benefits are lower uterine cancer risk, significantly lower ovarian cancer risk, less breast cysts, less PMS. There's a lot of things, less bleeding. And so there's a lot of reasons why That's safe, and we don't see an increased risk of breast cancer when we use birth control pills. So, many people say the birth control pill should have been labeled as a cancer lowering medication.
Fascinating. Amazing. Thank you for that. Dr. Menn, would you talk about cycling progesterone during perimenopause? I had never heard of that until I started to use it. And then I was alerted to cycling. What does that mean? Why would you want to do it?
Yeah, so typically we don't recommend cycling when you're menopausal, because we always have women ask, well, should I be cycling my progesterone once I'm menopausal to mimic nature? No, because what we're giving you is not full replacement and bringing you back to your cycles when you were 25. We're just giving you back low amounts of menopausal hormone therapy to alleviate symptoms and give you protection on bone health and other things. But when you're in the perimenopausal period, some women find it very helpful and really alleviates symptoms when we do cycle and kind of mimic what I had shown you in that image of that second half of the cycle, adding back a little bit of progesterone. And so we tend to cycle progesterone when women have fairly predictable periods. When the cycles are getting shorter than 24 days, 21 days, or if they're unpredictable where you're skipping them 3, 4, 5 months at a time, typically we'll do a nightly dose.
Okay, thank you. Are there any topical estradiol meds without parabens and SLF?
So, the topical preparations, my guess is this person might be referring to vaginal estrogen. So vaginal estrogen cream, I always bring examples, right? No, so the reason why, if you look, that there are parabens and other things in it is because, these are FDA approved. These are, produced in mass numbers. They need to be shelf stable. They need to last many days, right? Because this tube will last you quite a while, right? And that's why there's preservatives and other things in it, right? So I get it. People say, I don't want any parabens. And I respect women's wishes there. This is what we have that is FDA approved and commercially available. And the reality is, in my opinion, there's lots of ways in your life to avoid parabens, and using, 1 gram of cream a couple of times a week, you should worry about that. In terms of the gels and the patches, I don't know specifically what are the other components, in each manufacturer's one, but they're made in a way so that they're, again, shelf stable and that they absorb properly into the skin. And so, that's why there's other ingredients in them besides just estradiol. So some of those things we just can't get away from.
Thank you. Someone asks, and I think you touched on this in more or less, when is the best time in your menstrual cycle to give the doctor the best result to make a decision on HRT changes? I'm not sure if this question is about maybe switching from the birth control pill to MHT, or if you're reading this another way. But
yeah, I don't know. She might be asking about blood test. I mean, some women are asking, like, when in my cycle, if I'm going to give you blood results, should I give it to you? I'll tell you that if you're perimenopausal, I'd really rather hear, how have you felt this last month, this last week? What has changed? What's worked for you? What hasn't? That's going to be much more impactful. And I can hear it from a woman. If you tell me I'm bleeding more, I'm more bloated, I have more breast tenderness, well, we may have to lower your estrogen dose. If you tell me I'm having breakthrough hot flashes and night sweats, I still have lots of vaginal dryness, my periods are really light, you might need more estrogen, right? So we really need to listen to the woman. I think changing doses, typically we ask women, if we start something, at least wait a couple of weeks. Let's see how it's going. I never want someone to suffer for months before changing if it's either not giving them effective treatment for their hot flashes and night sweats. Things may not be perfect in the first week or two, but I would expect women on any given dose to start feeling some improvement in a couple of weeks. By 4 weeks for sure. And this is why, again, Aloe is great, is because you can message us at any point in time, and we can tweak things sooner. You don't have to wait 3 months. But if you're feeling pretty good, give it at least 8 weeks, because improvements kind of can compound, right? Because the more you sleep better, the more and so changes can be made and can be made at any time.
To what you just said, someone asks about pricing to join Alloy. To that, I just want to say, again, remind you to take advantage of the code that we're offering, the offer that we're offering, the promotion, excuse me, on myalloy.com to enjoy 40% off your consult with a menopause practitioner like Dr. Menn through September 22nd. So I really urge you, if you are not an Alloy member at this time, take advantage of that. But yes, to that, it allows you this dialogue, this consistent, regular, over time, as long as you are a member, communication with a specialist like Dr. Menn. The follow-up question is, I imagine practitioners are able to prescribe progesterone for early perimenopause symptoms?
Yes,
The
yes.
answer is yes.
Some women are seeking progesterone only. We can do that. A lot of OBGYNs, and I just had an Alloy, one of my patients this morning that I was consulting with, whose own GYN was like, honestly, she's like, go to Alloy because
Really?
she's like, I don't know how to manage perimenopause. So she goes, the only thing I know how to do is a birth control pill. And she says, tell Dr. Menn if she could send me some information, because I'm telling you, in training, all we're taught is a birth control pill, or for all the mood changes, start an antidepressant. And again, I don't want women to think that antidepressants are not an important tool. Some women come in perimenopause already on an antidepressant and suddenly it's not working anymore. Yeah. Or the knee-jerk response is just go on antidepressant because the practitioner is fearful of prescribing estrogen or doesn't know how to prescribe it. But yeah, progesterone and using that is something, it's a great tool, particularly for early perimenopause, because sometimes, listen, your ovaries are still making estrogen. Sometimes you don't need more.
Right. Yeah. Thank you. Thank you so much. Just to expand, I think a little bit more on this, how can I know whether I have the right doses of progesterone and estrogen? I love this question because it's
well, one, our goal is to meet your symptoms and minimize your side effects. Pretty simply, right? Using the standard FDA-approved doses, and we have a range of them from very low to higher, but all of them are safe and effective. And even the lowest doses in studies have been shown. We've got decent studies looking at what's the best dose for bone protection, for the protection against developing osteoporosis and bone loss. And what's been shown is that even very low doses have been shown to be helpful. Now, do we know the perfect dosing and regimen for the ideal preventative benefits that we talk about when women initiate hormone therapy within the ideal 10-year window, which we're always referring to? No, we don't, because they've never been done. We don't know what is the long-term ideal dose. Maybe one day we'll have that. But for now, we lean on to listen to your body. If you feel good, on any given dose, then that's the right dose for you. And what is right for you may not be right for your friend, right? Or your sister. Why is that? Why do some women feel great on the highest dose patch, 0.1, while other women feel much better on the lowest dose patch, 0.025? Well, we don't always know the answer. Some of it is age. Sometimes younger women in menopause, not perimenopause, younger women in menopause sometimes need more. Older women after many years sometimes need less, but also your receptors. So remember, in the end, it's not necessarily even the dose. It's the amount that your skin is absorbing. It's getting into your bloodstream. It's getting metabolized. It's making its way to your receptor, and your receptor may be more sensitive versus another woman's receptor may need a little bit more. And so I always tell women, just like in your reproductive years, when you were having normal cycles, some women have PMS, some women have fibroids, some women have painful periods, other women fly through their cycles and it's like easy breezy. Why? I don't know. Their receptors are probably different. And the same thing holds true as when they're using hormone therapy. It has to be individualized. So like try not to compare yourself to what your friends or your sister dose is, right?
Thank you. Dr. Menn, can you give us a bit more time? We're at
Yeah, I'm good. I'm good.
Great. Thank you. I'm 50 on Mirena and have had some peri symptoms, musculoskeletal pain, stress incontinence, constipation, vertigo while driving, acid reflux. The last 2 years, excuse me. Is there enough progesterone in Mirena to ease symptoms? Might doctor recommend removing the IUD before considering RHT? I'm sorry, HRT. My appointment is next month.
I'm sorry, how old did she say she is?
50.
So did she say that she's still bleeding at all?
She did not.
So listen, the average age of menopause is 51, so 51, 52, right? So if she's otherwise doing okay and she might need contraception, it's okay first. She's got all of the symptoms. We're listening to her, all the symptoms of low estrogen. Plus she's approaching the average age of menopause. The first thing I would offer her would be, let's add back some estrogen, right?
Mm-hmm.
Now, a progestin IUD, as long as it's been placed in certainly in the last 5 years, depending on, there's different types of hormonal IUDs, but the Mirena IUD, for instance, has been FDA approved up to 8 years for contraception, and so we typically will extend that time period that it's sufficient as endometrial protection if we're giving estrogen to relieve menopausal symptoms. So in her case, she can start with some form of estrogen. Now, I just want to point out that many practitioners don't understand that the progestin in the IUD is really working in your uterine lining. It is not the same as progesterone given systemically. So while some women may use the progestin IUD as the progesterone component of their MHT, and they just add back estrogen, what I find is in perimenopausal women whose ovaries are still doing things, remember like we showed you?
Yeah.
Some of those women, even though they have a Mirena IUD in, sometimes those women can benefit from systemic progesterone. So it really depends on her symptoms, particularly younger women using a hormonal IUD who are still having some menstrual cycles and some bleeding, and they're having these peri symptoms. You throw more estrogen on top of those ladies. I showed you in early perimenopause, they're still making a lot of estrogen. Sometimes they also need progesterone, but what happens is doctors get tunnel vision. They think IUD, oh, she doesn't need any progesterone. Sometimes she doesn't. Sometimes she does. But if you still think you might need contraception and you've been happy with the IUD and you're still at that transition time, I would not yank it out, because the risk is you remove the IUD and you start bleeding again,
right.
And so this is where the art and science of perimenopause comes in.
Thank you for that.
She has a ton of options. I love when my perimenopausal ladies come to me with the Mirena IUD, because I know they're not going to get pregnant. I know it's going to manage their bleeding, and then I can give her what she needs to manage her symptoms.
Fantastic. Thank you. What if I can't? Oh, I'm sorry. I apologize. We'll get to that question. Can you talk about estrogen and migraines?
Oh, can I have a picture?
Yes, please. Back to the pics.
Yes, nerdy Dr. Menn with her pictures.
I love
All right, so this is one of the most common things we see in perimenopause. So I have a picture for you guys because I want women to understand what's happening to their bodies. So I want you to focus on the top part of this graph, okay? So let's just talk through it so everyone understands what they're seeing. So on the bottom, so like basically they're starting at day 1 here, basically your menstrual cycle, right? The blue is estrogen. So let's just remember, like the beginning of your menstrual cycle, estrogen is lower, it starts to spike, and then you ovulate right around here, right? So see day 14, you would ovulate it right around here. And the orange line is progesterone. And in the second half of your menstrual cycle, you've got another bump of estrogen and the progesterone. So on the top, this top picture is what's showing is when women get menstrual migraines, right? So this can happen way before perimenopause. It happens to teenagers even, right?
Sure.
So for women in general, so hormonally associated migraines or menstrual migraines, the classic thing is a patient comes in and is like, yep, I have pretty regular periods. And right before I bleed, or the first couple of days of bleeding, my migraine, I get a trigger in headaches. Why is that happening? This is the highest migraine susceptibility window when women are still cycling, menstrual migraines, and you can see when it happens. So day 27 or 28, this means right before you get your period. And that's when all the hormone levels, boom, drop.
Yeah.
Or in days 1, 2, or 3, the beginning days of bleeding. Why? This is when your estrogen levels are lowest, and this is when there's been a dramatic drop. Remember, your brain is really sensitive to the changes in the hormones. So when it comes to migraines, it's this instability. Okay, so now look at the bottom picture. This is just showing from age 0 to age 80, all right? And so here, like you see around, your teenage years, your estrogen levels obviously are going up, right? So it's just kind of basically showing that, all right, you've got all these years with normal, regular estrogen production. So it's in the years age 45 to 55, roughly. So like those perimenopause, menopause transition, when you have erratic estrogen, that in the neurology literature, and when they've looked at this in studies, this is the age of the highest migraine susceptibility. Because not only are you having this can happen at the end of menstrual cycles, you're having all of this irregularity. So one other picture here. This is a beautiful picture. So estrogen withdrawal and menstrual migraines, right? And so the estrogen withdrawal, this is just another beautiful picture showing the lining is shedding. This is the end of your cycle. Estrogen withdrawal, estrogen's going away, right? This little like light pink, like little bar here, this shows this is the time of susceptibility. So how do we manage this in perimenopause? There's a bunch of ways we can do this. If you have a migraine with aura, you are often told you cannot use an oral birth control pill that contains estrogen. That's not necessarily true. Newer data and newer recommendations actually say that an oral continuous birth control pill is actually profoundly safer than we previously thought. So if you don't have aura, we often give you a continuous birth control pill so that we never have this dip here, and it's being stable. So that's one way to manage it. If you have an aura, traditionally I alluded to, we've been discouraged from using synthetic birth control pills because it could raise the risk of blood clot and stroke, okay, in women who have bad migraines with aura. So what do we do then? So what we can do, if we decided we don't feel good about using a birth control pill, although sometimes we can, what we can do is women who have these migraines, they know exactly when they're going to happen. It happens like clockwork. So this is where, again, this is where I've found my Evamist or other MHT to be really helpful. So we may, cycle you with progesterone or, give you estrogen during the rest of the month if you have other menopausal symptoms. But if you tell me that this is when your migraines are triggered, this is when we can give you your estrogen then. So I'll tell women, okay, you're using 1 dose of Evamist during the month. Well, when you get really close to those days where your migraines are going to kick in, give yourself 2 or 3 sprays, kind of beat it to the punch, because it's really that withdrawal. For other women, a stable dose of a patch can be super helpful so that they never have that dip. So there's a number of ways that we can kind of play with this hormonally. Again, there's a little bit of an art and science to it, but I hope this kind of makes sense.
Very helpful.
How it's really an estrogen withdrawal. And there's a number of ways to manage it. I mean, certainly migraine medications are helpful, but they're not helpful if we're not getting to the root of the problem, which is estrogen withdrawal.
Thank you. Thank you so much for that. Moving on to the next question. What if I cannot take estrogen because I have lupus and a blood clotting disorder? What other options do I have?
Well, what we would say is don't necessarily assume that you cannot take estrogen. So a blood clotting disorder and lupus, okay, those are reasons why we would not give you synthetic birth control pills, because the ethinyl estradiol and synthetic progestins have been associated, particularly in older women who have underlying risk factors like lupus or a clotting disorder, to be a much higher risk of blood clots and other things. But transdermal, low-dose transdermal estrogen is generally very, very, very safe for women like this patient. And it's important for them to know that lupus and blood clotting disorders is actually not a true contraindication for using safe FDA-approved menopausal hormone therapy. In these situations, we recommend starting with a lower dose, sticking with transdermal, sticking with real progesterone. If they need control of their bleeding and they need contraception, typically in lupus and blood clotting situations, we can use a progestin-only birth control pill that is generally safe. And then if we need to give back some estrogen, instead of using the oral synthetic estrogen and birth control pill, we can use a transdermal estrogen. But I find women with either a family history of blood clots, or they have a inherited mutation like factor V Leiden, protein C deficiency, or one of the MTHFR. There's a whole bunch of different ones that women are diagnosed with many, many times. Like all of their doctors have told them they can never use estrogen. And it's actually wrong. We have really clear studies and data on this, the ESTER study, Menopause Society guidelines. So yeah, consult with a menopause specialist, because you could probably get relief. And
thank you, Dr. Menn. I want to give you a second if you want some water to read this statement to you. It's not a question. Just want to thank Alloy and Dr. Menn for their help and expertise. I'm 46 years old, early menopause, with a thick endometrial lining. All of my previous OBGYNs would threaten to take me off of HRT, even though all my tests and biopsies came back negative. Dr. Menn adjusted my estrogen, progesterone, and that reduced my endometrial lining. She saved me from unnecessary procedures. I wish I'd found Alloy earlier. It would have saved me a lot of headaches. Thank you, Dr. Menn. We hear a lot of that about Dr. Menn around here, so thank you for sharing that. Can you use the estrogen patch while also on low-dose birth control?
Not with a combined birth control pill that also has estrogen in it. If you were using a birth control pill, that has actually a very potent version of estrogen, estradiol. And so if you are still having symptoms that are breaking through, either something else is going on, we always want to make sure we're not missing other things, right? Or you might be a person where we consider a change off of that birth control pill. Now, if you're using a progestin-only birth control pill, sometimes we can add in a little estrogen, but we don't do double duty with an estrogen birth control pill and extra estrogen. Yeah.
Thank you. Just a clarification question. Someone asked, did you say you would not prescribe progesterone to a woman who has heavy bleeding with a thickened lining during perimenopause?
I didn't say I wouldn't. It can be useful. One of the things that was very, very important that we discussed at the Menopause Society meeting, there was a whole lecture on it, was the management of abnormal bleeding and perimenopausal bleeding. And there's just a couple things that I want women to know. Not all bleeding is perimenopausal. Perimenopause can exacerbate bleeding. But endometrial cancer is on the rise, unfortunately, in our country, particularly in Black women. And many women who don't have good access to healthcare and they are not getting good advice. I have seen some women be written off that, oh, your heavy bleeding is just because you're perimenopausal. Now, that may be the case, but it could also be thyroid disorder. It could also be fibroids. It could also be polyps. It could also be endometrial hyperplasia, which is a risk factor for uterine cancer. And sometimes it could be uterine cancer. And it could also be pregnancy, okay? So there's a lot of reasons that we need to rule out. And so a good history, and when I get a patient's intake form, I can kind of, quickly get a sense of what might be causing their heavy bleeding. But I would caution women on two things. And these are important clinical pearls that were take-home messages from the Menopause Society. If you've gone to your gynecologist and you had an ultrasound a year ago and it was normal, and now it's been another year and your bleeding is worse or heavier, you cannot feel totally reassured because a year ago you had a normal ultrasound. A lot can change in a year, number one. If you have had a blind endometrial sampling, that means you've had perimenopausal symptoms and bleeding. Maybe you had an ultrasound, maybe you didn't. And in the office, they just put a little pipelle in and little suction, and we get a little sample of the uterine lining. That might be helpful, but it's only helpful if paired with a proper assessment of the uterine lining with an ultrasound and making sure that those images were done well and that we really saw the full lining. Because what happens, can I share my picture?
Yeah, please.
These are my favorite pictures. So I want women to understand a couple of things. Like, here's a picture of what your uterus should look like if we took away these yellow fibroids, right? The lining is thin and regular, and it's really not an open cavity. It's actually kind of compressed together. But you can imagine, so see this little fibroid that's pushing in here? So make that fibroid bigger, right?
Yeah.
So if your cavity is irregular and they can't really see or measure the full stripe, there's sometimes other imaging that needs to be done. So if we have a woman who has had a regular bleeding and she tells me that her ultrasound was normal, but the bleeding persists, sometimes we refer them to have further workup with a sonohysterography where they put some water or some saline into the uterine canal while they do the ultrasound, or something called an in-office hysteroscopy, where the doctor could put a little camera in. Because we always want to make sure we're not missing things like fibroids that are pushing in that could easily be removed and resected and can stop that crazy bleeding. So that's one thing. And I also just want to, while I'm just on this picture, kind of just point out endometriosis. So some women had endometriosis and they've known about it for a long time. And now it's getting worse in perimenopause because, just like that uterine lining builds up, what endometriosis is the cells of the uterine lining, instead of just being there, they're on the outside. Yeah. They're on your tubes, they're on your ovaries, they're on your bladder, they're on your GI, your organs, your intestines and colon. And so just like that lining gets bigger and bleeds each month, these little cellular implants do. So some women get new onset of worsening pain and bleeding. And then the other thing I want to show is that some women also have this condition called adenomyosis. So they'll tell me, Dr. Menn, my ultrasound was normal. The lining was normal. I don't have fibroids, but they looked and they can say that it looks like I have adenomyosis. What can I do in perimenopause? Adenomyosis is different than endometriosis. Adenomyosis is where the lining cells, there's like similar kind of glandular cells that normally should be in the lining that normally would get shed, but they're like embedded in the body of the uterus. And so every month, the entire uterus kind of gets, kind of this stimulation and can cause a lot of cramping and irregular bleeding and a lot of discomfort and pain, right? So I want to just point out that adenomyosis, as well as endometriosis and fibroids, sometimes in the perimenopause get worse before they get better. Eventually, once you go into menopause, these things shrink and then they get quieter. The good news is if anyone's ever told you had fibroids, endometriosis, or adenomyosis, it does not mean you can't have MHT. You can. Sometimes a birth control pill helps this. Sometimes other things need to be done. But I have to tell you, many times patients are told that these things are reasons why we can't have hormone therapy. And, it's not true.
It's not true.
Yeah.
Thank you, Dr. Menn. For the sake of time, I'm going to combine a few questions that came in that I think really speak to tweaking dosage. So one woman spoke about progesterone having worked and now it's not working so much. And another woman spoke about both progesterone and estradiol experiencing good symptoms initially, and now some symptoms are returning. There's several of that ilk. Can you speak to that?
Yeah, so just remember your journey from perimenopause to menopause, which I'm going to just assume that these women are perimenopausal, and then I'll get to if they were menopausal. Your hormones are changing, and it can be, what is working for you for a few months. The closer and closer you get to menopause, the more likely that, you may need dose adjustments, either up or down. It really depends on what's happening. The other thing is, and this is quite common, particularly in menopausal women, but also perimenopause, is that you've got a menopausal woman who's come to you, or a late perimenopausal woman, and they've been suffering for quite a while, and they've had lots and lots of symptoms. So at first, you prescribe them some estrogen and progesterone. They have great relief because those little receptors are so happy. It's like it's like they've been starved, so you
Right.
fed them and they feel initially happier, but then things kind of regulate and kind of settle in, and then they, you actually realize you kind of need to go up on that dose, right? And so, so you could have initial benefit and then, things level off. And I'd say this classically happens around 8 weeks to 12 weeks when we first start, right? So that's a common scenario of where things aren't working. And that's more likely in the menopause. In the perimenopause, sometimes what works at first sometimes doesn't work because they actually feel worse. They feel more breast tenderness or more bleeding. And again, I have to remind them it's because those ovaries are overriding things. Your ovaries are pumping out hormones that I can't control. And that's when things are trickier. And that's when we have to kind of sometimes we back off on the amount that we're, or sometimes we talk about using a birth control pill to suppress things, temporarily.
Thank you for that. Dr. Menn, we didn't talk much about sexual health, and it is Sexual Health Awareness Month in addition to Perimenopause Awareness Month. And a question came in. She says, I'm 48, serious hot flashes, mood swings. I got pellets, and these last few months have been horrendous. She had a hysterectomy in 2016. She still has her ovaries. She says, I feel so bad for my hubby, no sex drive, arousal, and low libido. Any recommendations?
Yeah. So listen, we don't recommend pellets, but I don't want women to feel guilty or bad if they got pellets. So the reason why many women get pushed to pellets is because their regular doctor is not helping them with their symptoms. And so they find in this menopause care vacuum a practitioner who promises them the world with pellets. The reason why we don't love pellets, and I don't know whether she got just testosterone pellets, often women are given testosterone and estrogen pellets together, is we can't control the dose or the rate of absorption. So this little pellet gets buried in your skin, in your subcutaneous tissue, and over time, months, and it could be many months, they either, they slowly break down, or sometimes you get a big surge, a lot of absorption, but it's very irregular. And we have seen women have hyperphysiologic, either very, very high amounts of testosterone and or estrogen, or sometimes they're not absorbing very much. And because we can't dig that out once it's placed, we can't, right? So that could be part of her problem. The other issue that I see a lot in perimenopause is that women get only testosterone pellets. Now, and we can talk about testosterone as that's a whole separate webinar.
Sure.
If someone is perimenopausal and they have hot flashes and night sweats and vaginal dryness and decreased arousal and low libido and all of these other things, insomnia, anxiety, this is an estrogen problem, right? Remember, estrogen is the primary hormone that we are losing in a dramatic way at that menopause transition. It's going from high and fluctuating to really low. Testosterone is typically, unless you've had your ovaries surgically removed, it's a slower downward trend over many years. It's not an abrupt drop. And while testosterone can be beneficial in certain women, the primary hormone that we are really concerned about in perimenopause, menopause is estrogen. And when I see women all the time, I'm like, they're only offering you testosterone pellets as your solution. You have to ask yourself, one, why? When we know all of our symptoms are estrogen deficiency. And so low libido can be from lots of causes. But let me tell you, if you're not sleeping, if the vagina is dry and less lubricated, if you're cranky and insomnia and anxious, you are not going to be in the mood to have sex. Right? And so I would say in her case, she'd want to speak to a menopause specialist. She likely sounds like she actually needs some estrogen. And that vaginal estrogen can be incredibly helpful. It's not the cure-all for libido, but we always want to treat the pain points first. So if sex is dry, if it hurts, if it feels a little bit like less sensation, it's harder to be aroused, harder for orgasm, it often speaks to the fact that you need more estrogen in the local tissues of the vulva, the vagina, and the clitoris, also the bladder. And so at any point in time, even if you're still having regular periods, we can give you back safe vaginal estrogen at any point. So in her case, there's a lot of things for her to consider. And when women have been on pellets and they come to Alloy or another doctor and they want to seek help, I always ask them, try to get try to ask, your pellet doctor to what was your last estradiol level and your testosterone level so that we know what we're dealing with, because the patients on pellets can have extremely high levels. And so we want to make sure that we're safely transitioning them, to proper, MHT. But don't worry, if you got pellets, eventually the
They'll
levels
exit. Yeah,
come
yeah.
down, and we don't have to wait. We can listen to your symptoms, and we can slowly, add back actually what you need.
Dr. Menn, you have been stellar and superb for going on 90 minutes. I want to let you go, but first sort of leave you a moment to wrap us up, either with a visual aid or just from the head and heart, and let us know, women in perimenopause, women who believe they may have entered into a perimenopausal season, or for younger women who are just interested in the conversation for any number of reasons, what would you leave us with?
Well, a number of things. One, you should be listened to. Your symptoms are real. Not every symptom is perimenopause, but in my experience and what the literature shows is that women will see many specialists, a neurologist, an orthopedic doctor, a rheumatologist, a psychiatrist. I mean, the list goes on, when actually someone needs to just take a menstrual history and a perimenopausal symptom inventory. So if they haven't done that for you, you can do that for yourself. Listen to what we talked about, all the symptoms. So take a menstrual history, track, let us know what's going on with your periods, what's going on with all of your symptoms, right? And what's going on with your bleeding, right? And know and be open-minded to all of these treatment solutions, because we've been conditioned to be sometimes a little knee-jerk angry about being offered a birth control pill.
Right.
Also, be understanding to be open-minded to MHT, because that may be the right thing for you. And that this is a really great opportunity. Perimenopause, it's a time of change. It's an opportunity to take stock of what's happening in your life. Also, your diet, your exercise, your sleep, your relationships, your sense of community, because all of the things, when optimized, can be really positive and really, they're the baseline. Like, I can give you a patch and help your symptoms, but if you are having really poor nutrition, you're never moving your body, we're not going to change things. But I also want women to know that sometimes they're told you've got to first do all of those things, and then only after you've optimized everything there can I offer you something. That's not true either. We can do it all at the same time, right? So that's important. And that please seek out evidence-based care from someone who is actually trained and is doing this all of the time, right? Just because, someone says, oh, I do menopause, look at their credentials. What I want to also just kind of end it is like a little shout out to the alloy doctors, because, and I got to meet 7 of them at the Menopause Society, but we've got a slightly deeper bench than that. But everyone here is so experienced, and we don't only know menopause, like we didn't just take the course and go to the conferences and get, we've actually all collectively for decades managed. We've been in the OR. I've dealt with the fibroids. I've done the hysteroscopies. I know how to manage heavy bleeding. I've diagnosed endometrial cancer, uterine cancer, and breast cancer. I know how it all works. I understand how to use birth control pills, and I understand how to, manage all the complications in women's health. So I can counsel women on not only, menopause, but kind of all the complications that come with these hormonal changes. And so you really do want someone who really has that depth of experience and isn't just, paint by numbers, menopause prescriptions, because we've been in the trenches, all of us.
You've been in the trenches, and you continue to share your understanding about the literature as it's expanding, which is also just so important. You're getting a lot of personal thank yous. And I want to say also, someone thanks you and says that you present this information in such an unscary light. And I that is very particular to you and all of our physicians, that there need not be anything scary here. We really are kind of held under thumb for forever, with fear, and certainly fear about our own bodies, health, and reproductive existence. And you do remove so beautifully all of that so that we can understand and get down the road truly feeling better. I want to thank everybody who came and certainly who stuck with us for 90 minutes. I can't thank Dr. Menn enough. It's always, always a pleasure to spend time with you and learn from you. We will do this. We will continue to do this, Dr. Menn and myself, sort of quarterly now, I think is our cadence.
I think in December, yeah.
Yeah. And again, I encourage any of you who are not Alloy customers to head over to myalloy.com, take advantage through the 22nd of this 40% perimenopause consult offer using the code Peri. And if you are late to that party, no matter, jump on anyway. You will be connected with a menopause specialist like Dr. Menn, if not Dr. Menn herself, and get on the way to feeling better. So thank you so much again.
Thank you for having me.
Thank you, everybody. Talk soon. Bye-bye.